Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Well, hello there. You know, sometimes I begin with the show talking about, well, today we're going to talk about some fun stuff and some not so fun stuff. Well, I'm going to cut right to the chase today with Doc and I, because we're going to cut right to the chase, and it's called sudden death and vein disease. Now, we don't want to scare you, but we do want to scare you kind of a little bit. The object of it is to expose you to all the different kinds of vein conditions there are, whether they're these funny little cosmetic, spider veins on your legs, or with it's a deep vein thrombosis, or you are at risk for even worse stuff. That's one good thing that you need to do, and I've learned this ever since Doc and I started doing the show, is that everybody has something. You just have to find out where in the big picture you are. Are you in the 6 different stages of vein disease? Are you a 1, a 6, or somewhere in between, which is where most of us are? So but at the other end of the thing, Doc, when we say the word sudden death, number one, it gets everybody's attention, right?
It does.
Yeah. I mean, like a car accident, sudden death.
Right.
But, it doesn't need to be completely unexpected. I mean, there must be some signs that we can talk about and some other things today.
Sure.
Whether we can take a look at it. So, and what we're talking about today, gang, is sudden death with respect and vein disease. There's all kinds of other things that can take your life away, as you know, but this particular one is Doc's specialty. And so I guess it doesn't happen to a lot of us, but those that it does happen to, they're not so lucky.
Right. Yeah. I wanted to go through, some of those things that do cause, sudden death. Vein disease can. I mean, often we don't think of vein disease as being that, monumental that it might lead to somebody, keeling over. Mm-hmm. But there are specific situations in people with venous disorders of one form or another that can definitely lead to sudden death. But you're right. So I also want to go sort of in a general sense over a number of other reasons why people might develop or suffer sudden death. And your comment before is absolutely right. Often there are precedent symptoms that people ignore. Sometimes they're not. Sometimes there are none. Which is why they call it sudden death. But about 1 in every 100,000 people in this country each year die, an occurrence that we would consider to be sudden death. That's the ages of 1 to 35.
Mm-hmm.
So that's a young population. Yeah. Typically we refer to that as that they're dying from natural causes, usually it's there always is a cause. I mean, it's whether it's natural or not, who knows? But there is usually some inciting feature, and that's why we call it natural causes. Although often we are not able to completely define why that happened.
Yeah. See, the reason we get together and do this for you or with you is simple. First of all, if you've been listening to the program, or if you are already a vein patient somewhere, we've learned over the course of the program that vein disease accumulates over a long period of time. So you don't think something that's accumulative over a long period of time as being a sudden death, because that wouldn't be sudden. That would be at the end of a long time. Yeah. But it is sort of interesting that as we age, those of us with venous problems, you do get to a point where you can see it's accelerating, but it's very, very slow. So it must come as a surprise to some people, or a lot of people.
Yeah, because in a lot of people they either
no symptoms.
They have a few symptoms, or or they have symptoms that they don't necessarily relate to venous and cardiovascular disease, or they don't, they just don't know. They haven't been educated or turned on to the idea that they have a problem that we can do something about in particular. But most of the causes for sudden death are cardiovascular in one form or another, either due to the heart or the circulation, whether it be arterial or venous. But most cases of sudden death occur due to some cardiac abnormality, something having to do with the heart. And often when you do an autopsy on people that have suffered sudden death, they'll find some structural abnormality of the heart that they can actually see anatomically. Often it's a structural abnormality that leads to a rhythm problem with the heart, but sometimes even then, 15% of the time, an autopsy is done, and there's no clue as to really why that patient suffered sudden death.
Interestingly enough, gang, Dr. Julev, a vascular surgeon, originally was a heart surgeon, and so it's a lot of people, I think, and I'm one of them, that don't realize the correlation between the veins, arteries, and the heart.
Sure.
You kind of think, well, the veins are down there in my leg, the heart's way up here.
Right.
So they're kind of connected, but not really.
Yeah.
But in actual fact, it's all about the heart spewing this fluid out called blood. It's all over your body.
Right.
And then the veins bring it back for it to happen some more.
Yeah, I mean, it's definitely all connected.
Yeah.
And in one side can affect the other, very dramatically, especially when you're, kind of throwing in heart function there too. But with respect to the undiagnosed kind of patient, periodically you hear of these young athletes.
Right.
Who are, totally physically fit, and for whatever reason they suddenly pass out and they end up dying. Sometimes we don't have the answer.
That was just in the paper the other day. Young guy, 17 years old, football player, selecting from any number of colleges. Everybody interested in this kid, a real phenom. No drugs, no alcohol, no nothing. Drops dead on the practice field.
Right.
And so he was a real puzzlement until the doctor found out, well, I guess an autopsy revealed that he'd had this heart murmur his whole life. And it just got to him that day.
Yeah, some kind of congenital defect of the heart, either the structure of the heart or the electrical conduction system of the heart. And, boom, it caught up with them, sure.
The interesting thing is, because you call it a circulatory system, it indicates that there's some energy needed to propel this stuff all over your body. And you don't think about it. And then you mentioned off the air when we're getting ready to do the program today that, this is a pump that's going on in there, and it has its own thing. They're all a little bit different, but basically, where does the power for the pump come from? You don't have a battery, do you?
No, you don't do that. That's actually the first category. There's 5 common causes for sudden death, and the first one has to do with this thing that we call arrhythmia. And arrhythmia means that for whatever reason, the natural rhythm of the heart was interrupted, and it became incompatible with life. And that's probably the most common reason why people would suffer sudden death. Now, there's a number of different reasons why that happens. There's something called cardiomyopathy, which is basically just a disease of one form or another. There's a whole bunch of different forms of the heart muscle itself, which eventually then interrupts the electrical activity and the rhythm type function, and that can lead to a rhythm that suddenly occurs and the patient dies from it. There are inherited defects, like the young guy you just mentioned. That was a congenital defect. Heart attack is probably the most common cause of reason why somebody would have a sudden change in the rhythm of their heart. But other less common things are electrolyte imbalance.
Sure. That could happen to anybody.
Well, almost anybody, but typically people with kidney disease. And you mentioned before illicit drug use, heart failure, and we one of the ways that there are a number of these kind of people who are surviving, this event is the use of automatic defibrillators.
But they're popping up everywhere, aren't
they? They are, yeah. Over the course of the last 15, 20 years, there has been a real initiative to get these, automatic external defibrillators in public places.
I got to tell you something, and it's not a coincidence, but I've been a lifelong fisherman, and some of my friends and I were all senior citizens. And this one guy's got this beautiful big boat. We just voted unanimously about 6 months ago to participate in a fundraising project for a defibrillator for the boat.
Yeah.
Because quite often these guys, and I'm one of them, we're 30, 40, or 50 miles out to sea fishing.
Absolutely.
And so, in the best of times, that takes a long time to get somebody in a helicopter and move them. And when you're in that area, if somebody knows how to use it, you just got to think, bust out the thing, we need it.
Right, yeah. Yeah, people refer to those as AEDs. They've saved many lives over the course of the years that they've been using them. Originally electrical, what we call cardioversion, converting an abnormal rhythm to a normal rhythm. We always had that just in the hospital. That was the only place we had it. But again, over the past 20 years, we've had these, mobile kind of compact sort of things that when used properly, and they've got a step-by-step.
I'm glad you had that little caveat.
Yeah,
when used properly. Don't think I don't feel so good today. I think I'll zap myself. You don't necessarily want to do that.
Yeah. But they're pretty easy. I mean, they're user-dependent, no question about it. But they've got a very easy to understand step-by-step process, and they're very, very automatic. And, they've saved a lot of lives. The use of these AEDs over the course of whatever period of time we've had them, it increases survival by 4 times.
That's amazing.
So that's a lot of lives.
Well, let me ask you this, because I think everybody's seen the TV shows where they get the guy in and they clear and boom, and this guy flies off the bed about 3 feet.
Yeah,
I understand that there was. In the initial stage of this, maybe they might have been using a little bit more power than they really needed.
Right.
And on consequence, the guy flies up off the bed.
Yeah.
But that does happen. Then it's just this big contraction.
It is. You've got some muscular contraction. It's just, structure, body muscle contraction that occurs when that electrical jolt hits you. And I think way back they were using a lot more energy. Now in the hospital, when we kind of start out at the lowest energy we can, and then we kind of increase it. But another reason is I mentioned before acute myocardial infarction, acute heart attack. That is often something that will lead to an abnormal rhythm. Again, having an AED around is very important if you have it there with you. But myocardial infarction is one of those things that may have had that person may have had precedent symptoms that possibly they might have ignored, and usually chest pain is the main thing. That's the most common symptom for what we would refer to as coronary ischemia. That means not enough blood getting to the heart muscle. Typically that's due to plaque formation in the little arteries that go to the heart, but there are other symptoms too, things like difficulty breathing. Somebody who finds out or observes that doing the same sort of activities that they're used to doing, they're getting a little short of breath when that happens. Well, that's a symptom that should not be ignored. And you should refer that information to your physician and see if it's important or not.
I'm guessing that some people are in denial about that, and they don't really label it for what it is. Case in point, my wife and I was at the doctor. We were talking over a bunch of stuff, and he said, "Do you often get shortness of breath?" I said, "No," and she said, "Yes, you do," because sometimes a person that says, "Well, do you snore?" No. How do you know? Because I'm sleeping.
Right.
No. Yes, you do. Here's a recording. So I mean, isn't it interesting that your body does send out these warnings? One of them might be shortness of breath. So you should actually say, wow, that's shortness of breath. I better talk to somebody about
Yeah.
that.
And part of the problem is that, many of these symptoms come on slowly over a long period of time, and that person kind of gets used to it. However, it's good for a family member or a close friend or whatever to make that observation to kind of bring it home to that person to make them a little more aware of it too. So
one more question, and that is when we often use the word heart attack. Is it the heart attacking something or something attacking the heart? In other words, why do we call an episode of a heart problem a heart attack? Because obviously something is attacking the heart's ability to do its thing.
That's a good question, Mike.
Yeah.
Very good question.
Whoops! Every now and again, I stumble on these blockbusters.
It's a very good question, and I'm not quite sure I know the answer. Yeah, it's been part of the vernacular for so long. I don't know, but it's not with respect to your question. Is it the heart attacking something or something attacking the heart? But it's neither. But basically what's happening is that there's a sudden lack of blood flow, to a particular part of the heart that is, causing, a number of different things. It can cause death to muscle, which is not a good thing.
Sure.
It can create electrical instability, like we're talking about right here. Or it can create just abnormal function that is going to persist and not be ever normalized again if there is not some sort of intervention.
I've heard that the interesting part about this, gang, is that the heart is going the whole time you're alive. Mm-hmm. It's unlike other parts of your body. You can go to sleep. You don't use your legs. No problem. The heart's going whether it's no vacations.
Right. Yeah. No time off.
Yes.
No time off.
So if you have an event, i.e. a heart attack, something's going to suffer. Some part of your body's not getting what it needs for a undeterminable amount of time in some cases, I would imagine.
Right. Yeah. Right. And in particular, heart muscle. The immediate event is a lack of blood flow to heart muscle, which is not good. So, the other thing, a couple of those symptoms, something we call diaphoresis, which is, somebody gets real sweaty, abnormally sweaty with, a limited period, again, sort of a limited period of activity or, activity that would not have previously caused that kind of symptom to occur. That's something that's abnormal and should be looked into. Dizziness, which would be a central nervous system kind of symptom, or GI symptoms, nausea, vomiting, a feeling of bloating. All of those are symptoms that, although they're not typical, they can be related to something happening to the heart, which should be looked at.
Yeah, it's incredibly interesting, and I guess we all get a little wiser as we age. If they say that every time I hit my thumb with a hammer, it hurts. So the answer is, well, don't hit your thumb with the hammer anymore.
Right.
So what happens is when these symptoms develop and you can identify what they are, and that's maybe you can spend just a brief moment say on how some of these symptoms don't necessarily have to do anything with your heart, but they're in that vicinity. So it's quite often you need to do a process of elimination to find out where the problem is.
Yeah. It can be confusing. Yeah. Chest pain is pretty obvious. Most people know chest pain, you got to worry about your heart. But the last thing that I mentioned, GI upset.
Yeah.
Bloating and, even heartburn, that symptom that is typically related to maybe eating something that doesn't agree with you or whatever. If you have those kind of symptoms repeatedly, you might end up going to the doctor and they need to look down into your stomach and they find out that there's nothing wrong there. Well, then you got to look for other reasons why you might be having that symptom. I think that's what you're referring to.
Well, it is. And, by the way, if you go to veinclinicsofhawaii.com, you can see some of this talked about. We'll point you in that direction again a little later on. But what I've always thought was interesting, we often talk, Doc and I do, about these TV commercials and how they have to spend so much time telling you what the adverse effects may be. It also, I was just thinking about that when you talked about acid or reflux, that there was this one thing being advertised that literally said, okay, well, you're going to get it, but here, take the pills. You know, and I'm thinking to myself, wait a minute, isn't that sort of promoting? Don't worry about what you eat. As long as you take one of these pills, you're going to be okay.
Yeah.
Isn't that just sort of masking what you're doing? It's not really fixing it, is it?
That's called marketing.
Yeah, exactly. Great job.
Yeah.
Go ahead and pop a couple of these purple rascals before you eat your tamales or whatever.
Right. Yeah. Heaven forbid, don't stop eating tamales.
Yeah, of course. But I think where it's interesting is we've all become a lot smarter with recognizing some of these symptoms. But even the most trained eye, and you've explained this before, there is a curve that you have to do anytime you have a new patient, determining, is this somebody that needs my specialty, or do I need to move them along to the next guy because the symptoms are similar in both cases?
Yeah, right. Yeah, and that happens all the time.
Yeah,
sure. We see people who they need somebody else other than us, and then we refer to them to other physicians. But so the third category now for potential sudden death is what would be referred to as intracranial emergencies inside the head, inside the brain. And we separate those two things into what we call hemorrhagic and non-hemorrhagic. Now, what that means is either there's something where a bleeding episode has occurred, somebody has
in the brain,
sudden bleeding into the brain, or like a heart attack, there might be a sudden lack of blood flow getting to a particular portion.
I was going to say, can it be just to a specific part of the brain?
Yes. Yeah. And usually it is.
Okay.
Usually it is. And the non-hemorrhagic events have to do with either usually it's vascular disease related. It's either plaquing within the brain arteries, the cerebral circulation itself, or there are problems with the circulation leading up to the brain. We've talked about the carotid arteries in the neck, and when they develop plaquing, sometimes those little pieces of plaque or calcium can break loose, go downstream up into the brain, and that little piece of plaque can actually interrupt blood flow to an area of the brain, and that creates a stroke.
Yeah, and boy, there is so much going on up there. I'm telling you, everybody wants to say, I got the answer. But from what I understand, sometimes it takes a pretty thorough vetting and examination to really be able to nail exactly what happened to a client, to a patient. Yeah,
sure. Yeah, I mean, you start with the symptoms, and then the examination, and then from there you go to either a non-invasive or even invasive testing to figure out exactly what's happened. But luckily, again, this type of program has been developed in more recent years, and by that I mean the last 20 years or so, where we've gotten a little more aggressive with trying to help people who have the non-hemorrhagic form to try to, so that event has occurred because of a lack of blood flow. So there are things nowadays that we can do to reinstitute the blood flow to that area so that it doesn't become permanently damaged.
Yeah, we talked. Let me ask you about this too, because it's in the same vein, I think. Excuse the expression, I don't mean vein. It's the same category, and that is a lot of people that say, "Well, I don't know how you're so lucky. I get these horrible headaches a couple times a week. I'm just debilitated. I got to go home. I don't know if they're migraine. I don't know this. Sometimes I have plenty. Sometimes I don't." And then you get guys like me who, for some stroke of luck, I don't even know why, I can't remember when the last time I had a headache was. I get other aches.
Yeah.
But so let's talk about that because that's up there. And for most people, the headache is in the brain. I mean, it can happen in a lot of other places in the skull, right? But basically, there's something going on in the brain. What causes a headache? Is it lack of blood?
Well, it's often a vascular-related kind of thing.
That's what I'm thinking. Yeah.
When we think about hemorrhagic strokes, which is the other type of event that happens, often people will complain of the worst headache they've ever had as a symptom.
Reading that. Yeah.
Of a hemorrhagic stroke. So, and in that situation, we've got maybe a blood vessel that either has developed a little aneurysm, a little outpouching of the wall, which is abnormal, obviously, or a weakened area of the wall, and that wall can break down, and blood then starts to go out into either around the brain or into the brain itself. And as you might imagine, when that happens, suddenly people are going to develop a headache. So that's one of the kind of premier signs or symptoms of a hemorrhagic stroke is a very, very bad headache, which needs to be looked at.
Yeah, it's interesting because I heard the other day of a guy that was a headache specialist. And now we have a lot of docs that are moving into the pain management area, or in other even more definable, little parts of the pie. And so obviously, if you have a headache and you found that there's this one pill I take, if I get this headache, the headache goes away. It may not be a good idea to always do that. Instead of saying, okay, I'm going to do that right now because it's Saturday afternoon, I'm at home, but I got to go see the doctor because I don't want to have to take these things all the time.
Yeah. Or it might be a sign of something, more monumental going on.
Yeah, exactly.
Sure. But, headaches in general, I think they're, they can be related to, stress and, muscular things, with respect to your neck and skull. But there are plenty of, vascular sort of related, or neurovascular kind of reasons why people might have repetitive headaches. I think what we're talking about here is just a real severe headache.
Well, one guy found out, he thought he was having migraines and he had a bad pillow.
Yeah.
Somebody said, your neck is always stiff. What kind of pillow do you use?
Yeah.
I don't know. This thing's like a brick.
Yeah.
Yeah.
Probably wasn't a my pillow.
But what I'm getting at is it seems to me that some of the stuff we're talking about today, because once again, the title of today's program is Sudden Death and Vein Disease. That what we're really looking forward to is to see that if some of you are going to need to get looked at because you might be manifesting several of these symptoms, which is a pretty good idea. One thing I was reading through your materials, Doc, and it got me scared, is because one part of it said that a large percentage of sudden death cases, 25%, that's the symptom. It's all of a sudden, boom, somebody's gone.
Yeah, the first symptom
of
whatever it is that's causing sudden death is, is the event. So it's unfortunately there are a good number of people who don't have preceding symptoms, and it's just unfortunate.
Well, that's why when you said earlier, a lot of these people are young people. It's even more puzzling, isn't it?
Right.
That they didn't enjoy the blessing of time to have a lot of things go wrong over a long period of time.
Yeah.
Okay, so but there obviously must be more than just a little glimmer of hope, or a ray of sunshine coming in, this sort of light in the tunnel. Is what are some of the things maybe that you, as a vascular guy, you look at these things and say, some of what you're having here is because you've got bad circulation, you've got ulcers, you've got problems in your legs, in your veins.
Which is actually the next category that we're going to look at, which is related to vein disease, and that category is pulmonary embolism. And we've talked about that before on the show, but pulmonary embolism can be cause sudden death, and that's something that's pretty common in this country. 60 to 100,000 Americans die every year from DVT or PE, pulmonary embolism. And that number is probably a little understated because we don't probably know or recognize a lot of people who are, again, dying suddenly because of that. But 25% of people who have a PE and die from it, that is their first symptom.
Interestingly enough, I'm seeing some of these TV commercials that I mentioned time to time that now deal with both things, DVT and PE. So they're just trying to say, look, hubby might have that and wifey might have that, but they're both at risk.
Well, they're so DVT, blood clot, typically in the leg or pelvis. It's so related to pulmonary embolism because most of the time the blood clot that goes to the lung is coming from your leg or pelvis. That it really is a topic that you kind of have to consider together. And obviously the treatments for each are, similar.
Yeah, I was going to say that. The family that medicates together, right?
Yeah.
So you might have somebody that has a DVT and somebody else that has that are literally taking the same medicine. Is it my imagination, or more and more people being prescribed and using blood thinners? I mean, I happen to just see a lot of it on television.
Yeah,
I'm taking one of them myself, and you wonder, gee, if I'm taking this, is this a forever sentence? I mean, why does somebody need a blood thinner?
I don't know that there has been that much of an increase in the number of people who are actually being treated with blood thinners. Although, as we go along, as time goes on, we are recognizing, more reasons why people might need to be on blood thinners, and most of those are what we call hypercoagulable, inherited defects that make people, their blood clot easier than it should,
sure.
or is normal.
And by the way, we're talking about that. Here's one thing that if you've learned over the program, and Vein Clinics of Hawaii, as you know, on 4 islands are bringing you this information, 4 different ways for you to get treated every time you get into one of these situations. I think what's incredibly interesting about this is that, you have something going on in there, and once you sort of get it, you get it. And I'm guessing that you're right, that maybe it's a combination that we are living longer, and that sooner or later some of these things that may have never shown up are showing up sort of in your 70s or 80s. And
well, that's part of it too, I'm sure. Yeah. But the other part of it is that, and I think this is why you see more marketing endeavors concerning anticoagulation or blood thinners, is that for many, many years we had one medication. It was called Coumadin or warfarin. And a lot of people have heard about that drug. It was a good drug. It was good because it did its job very well, but you had to monitor it very, very closely. People on Coumadin had to have their blood, checked every month or so to make sure that it wasn't, too effective or too little effect. However, in recent years, there have been a new class of anticoagulants, a new class of blood thinners that have come out where you don't have to worry about monitoring it as closely as we did Coumadin.
Sure.
And we see a lot of those kind of commercials on TV anymore. Again, so I think it's primarily marketing, although, yes, people are living longer and needing it in some instances. And we're just, learning more situations where it would be effective and beneficial for the patient.
Although there have been some things, and I've looked at and I've heard this, and I've even talked to people that it's happened to, is that they're told before surgeries, if they're going to have a hip replacement or whatever, that you're going to have to go off your blood thinners for a while, because once you start making a big hole in somebody, if it's easy for the blood to get out, it's going to go away, isn't it?
Oh, yeah.
But what I think is interesting is, does that also make that you should be careful if you are on blood thinners, especially dramatic ones, that you don't put yourself in harm's way? You don't want to get cut. You don't want to get hurt.
Yeah, there are some activities that if you're on a blood thinner, probably you should avoid.
You know, one thing I needed to ask you, and I made a note about this, and even though this program doesn't exactly focus on it, I do know that, when you take a look at some things and you think, all right, I'm at risk for this, but, everybody seems to be now talking more and more and more about falling down. And I guess when you see a little kid fall down, if they cry, it's only because they can see somebody. The little kid falls down, they just bounce up and go about their business.
Yeah.
When you're 70 and you fall down, you don't bounce up. There's something, as a matter of fact, everybody's seen that funny commercial. I've fallen and I can't get up, but that happens a lot, doesn't it?
It does. Yeah.
And I'm talking about people with venous conditions that, just have a symptom, and all of a sudden they stand up and they didn't realize that their body weight's not going to get supported by that leg. Right down they go.
Mm-hmm. Yeah, that would be one instance.
Yeah.
But youth is a wonderful thing.
Yeah, so again, we can't bottle it.
Yeah. So, with respect to DVT, PE, what are the things that we worry about with respect to putting somebody at risk for developing a DVT, a blood clot in their leg, that then might evolve into a pulmonary embolism? There's 3 risk situations. The first is stasis. Now that we mean, lack of activity, and immobilization. So, either a patient or a person is in the hospital, or they're laid up sick, or
you hear that a lot, don't you?
Or as we often talk about, people that are on long plane rides. You sit down, you're not getting up and around, and your muscles are not, contracting and being active, and that blood becomes static. That's what we mean by stasis.
Yeah.
And that makes that blood then more susceptible to clotting. Another reason is what we call hypercoagulable. Patients who clot, easier than they should. Some of it's genetic. Some of it is medication related. So, you have to consider, some of, hypercoagulable states occur in other situations like pregnancy. And when people are sick with cancer, they're automatically hypercoagulable. So, and then the third one is some sort of vascular injury. Those are the three things that really will, cause a clot to occur and possibly propagate and possibly turn into a pulmonary embolism.
Yeah, and that, by the way, is where we're going to go next. And I tell you why. First of all, I think when people hear the word pulmonary, they may not realize what a large field that covers. It's not just one thing. When we talk about pulmonary and embolism, what is that?
Yeah, that's a blood clot that again typically starts in the legs or the pelvis, because there's a bunch of very large veins in the pelvis where blood clots can happen. And for whatever reason, a clot might become dislodged from the leg. Usually it's the upper leg or the pelvis, and then it follows the circulation up. There's a big vein that all veins, below the waist kind of empty into. It's called the inferior vena cava. And the inferior vena cava is just one really big vein. And that carries, most of the blood coming from your body back to the heart. That's the main blood vessel.
By the way, when you say big, I want people to get a perspective of this. Some of these veins that we're talking about, that Doc puts a wire into. The wire is really small, and the vein that it goes into is really small. This one you're talking about gets bigger than your thumb. It's like a hose.
Yeah, it's a couple inches probably.
Yeah, it's a
maybe
big
even more, like 3 inches. But it's a big vein, and it carries a lot of blood. Yeah, it's like the Mississippi River. So a clot can break off and follow the circulation upward through the vena cava into and through the heart. So it doesn't stop in the heart. It gets pushed all the way through, and then from the heart it goes into the lungs, and that's where it creates its problem. So, with respect to sudden death, we're talking about a pretty big blood clot.
I should say
that's going to occlude essentially the blood flow to a very large part of the lung, or even both lungs.
I'm assuming when you talk about something that big, it's not easy to grab.
No.
It's got a mind of its own.
It's not going to stop. Once it's on its way, it's not going to stop. That being said, however, there are many situations where people have pulmonary embolus, and they survive. They do fine. Sure. We treat them. The majority of people do not die from pulmonary embolism. But pulmonary embolism is one of those things that can cause sudden death. And the point here is that if you have other signs of vein disease, like varicose veins, swelling, skin darkening, and that kind of thing, then you are at a little higher risk to develop a DVT, which then could propagate and develop into a pulmonary embolism and potentially be fatal.
Yeah, and by the way, when you start calling it a pulmonary embolism, you're talking about a pretty bad character that is just looking to cause mayhem somewhere. What are the things that can either prevent it on its route or deal with it if it gets there?
What are the things?
Yeah, what are some of the things? Obviously some of the surgery procedures that you do, when you can see them, when you can find out, would be the choice. Get rid of that thing, get it out of there, kill it, move it.
Yeah, most of the time, when somebody suffers a pulmonary embolism, most of the time we treat them with blood thinners.
Sure. Yeah.
And luckily, your body, over a period of time, is going to break that clot down. The blood thinners don't dissolve the clot. The blood thinners just make sure that the clot doesn't get bigger. You know,
Gotcha. I get you.
And it stabilizes whatever clot might be left in the leg. But the blood thinners don't dissolve the clot, although there are medications that can. And if somebody comes in with more substantial kind of symptoms, are they short of breath? Is their oxygen level, dangerously low? Then we might start those people in the hospital on what we call a thrombolytic or a clot buster kind of medication.
Gotcha. Yeah, I was going to ask you about that because earlier you talked about, take this and take that. They're blood thinners. You mentioned Coumadin and warfarin, I think, which were, the ones of choice standard. Now things are shifting a little bit to other ones. But what about the age-old one? You take everything off the shelf and have the little aspirin in the corner. Sometimes you take a baby aspirin.
Yeah.
Isn't that in its own respect a blood thinner?
It is, but nowhere near as strong of a blood thinner that you would want to take for any dangerous or important kind of blood clot. Okay. And I'm glad you mentioned that because a lot of people will do that. They'll think that taking aspirin is adequate therapy.
I'm on an aspirin regimen. You hear?
For a blood clot, and no, it is not. You really, if you have a significantly placed and sized and threatening kind of blood clot, you really need to be on a blood thinner.
Mm-hmm. Yeah, and so remember that. And then there's another thing. I've learned the importance of this. Actually, the last time I was at Bain Clinics of Hawaii's office getting checked up, there is a list of things that your physician needs to know that you're taking, even if they're not prescription. I mean, you might be taking a multiple vitamin, or you might be taking that baby aspirin because your uncle told you to do it 5 years ago. These things all accumulate, don't they? Mm-hmm. You need to know what I'm taking.
Oh yeah. We ask that question of everybody. Yeah. So and there are even more invasive kind of things that we can do for people who are really dying from a pulmonary embolism. They're pretty extravagant, but luckily most people don't get to that point. But so the next category is what we refer to as aortic catastrophes. Now, the aorta is the main big arterial blood vessel that goes down the middle of the body. It comes from the heart, comes out of the top of the heart, goes down and basically supplies the entire body with blood. And there are sudden and catastrophic things that can happen to that blood vessel that, can cause sudden death. Probably the first and most common one is aortic aneurysm. And we've talked about this a bit on the show before, but an aneurysm is a ballooning out of an artery in whatever location. But it's just that the aorta is a fairly frequent place where those, that type of ballooning out can occur. And the most common site for an aneurysm in the aorta is in the belly. Mm-hmm. And I think many people have heard of aneurysms in the belly. Now, many people, when you talk about aneurysms, they think about aneurysms in the head
think about
too.
The brain, right?
And that falls under the category of a hemorrhagic stroke. But this has to do more with the fact that as an aneurysm gets bigger, the wall gets thinner and weak, and at some point, at some size, that aneurysm is going to rupture. It's going to break open, and you have a lot of blood loss.
I do know as a patient, if you're being managed or if you have venous disease, if you're one of this group of us, thanks, Mom, that you inherited from, it is what it is. And I do know that you can take a look at a clot, for instance, and just monitor it for a long time. Mm-hmm. It may be in a part of the body where, number one, it's not big.
Right.
It's in an area that seems to have pretty good circulation, but it's there. And you keep taking a look at it. And then at one point in time, it must either increase its symptom or you just get a lucky bounce where you're getting examined with ultrasound or whatever you're doing on an annual basis and say, all right, we've been watching this. We got to do something about it now. It's to a point where we can't just leave it alone anymore.
Yeah. Well, aneurysms are like that.
Yeah, that's what I'm asking.
We monitor blood clots, sure. And if they're not in a threatening location, that's what we do. We monitor them, and we may or may not treat with blood thinners. But aneurysms, we do that all the time. We follow the size an aneurysm, and once there are indicated kind of sizes for each part of the aorta, which once it gets to that particular size, then intervention is warranted. But yeah, we typically we follow the size of an aortic aneurysm, particularly in the belly, with an ultrasound. Pretty easy test. The other place that you might develop an aneurysm of the aorta is in the chest, and those can be particularly threatening. Obviously, they also are susceptible to rupture and sudden death. Typically, we follow those with CAT scans. Okay. And once they get to a particular size, then, again, some sort of intervention is warranted. I guess the good thing about aortic aneurysms now, over the course of the past 10 or 12 years, we've done percutaneous kind of interventions rather than doing huge operations. We've been able to, do it percutaneously and put in something that we call stent grafts.
Yeah, and that's one of the reasons why we do the program. Because many of you listening, because as you've learned over the decades here that we've been talking about this, is that what it is, it's generally genetic, and you're going to get this probably part of your family. But the way the family used to get treated and the way the family is getting treated now, it's like day and night. There are just massive, massive differences in what can be done in the doc's office. You walk in, you have a procedure, and you walk out. You're not in the hospital. You're not at big risk for something going bad, but it does lead you to the point where you need to have that trust or that confidence. You need to be diagnosed to the point where you're given, first of all, a report on how you are, and then treatment options.
Mm-hmm. Sure.
How good do you want to feel? This doesn't need any help, but if you did get rid of it now, it would enable you to do some things that you're not comfortable doing now, or whatever. It's just, you have to make your own decision.
Sure. Yeah. Now, with respect to symptoms, with respect to precedent symptoms, which is what we want to keep an eye on, are and as they relate to aneurysms of the belly in particular, you can have some abdominal pain. Sometimes people, especially if you're a little thinner, you can actually feel the pulsation of the aneurysm as it gets bigger and bigger. So, if you feel something like that, it might be time to go to your doctor and say, hey, what's going on here?
Yeah. If you feel it, you got to get rid of it.
Yeah.
What we're looking at here. Yeah.
Well, if you feel it, it has gotten to a size that is would probably warrant some kind of intervention.
By the way, when you say size, I was talking to a friend of mine the other day whose dad's a doctor. And one of the things that he specializes in is these abnormal growths and the removal of them. Mm-hmm. I mean, there's lots of ways people get these things. Are you sometimes surprised at how large these aneurysms can get?
Yeah, definitely. Every now and then you're taken aback by the size of an aneurysm that you run into. But unfortunately,
it just doesn't talk about elasticity. It talks about something that once it gets to be really large, I imagine having it burst is a real problem.
Well, and that's the other thing. As they get bigger, the likelihood of them rupturing goes up.
Sure.
I
would guess exponentially, yeah.
And so once they get, the old number was 6 centimeters, and once it gets to be 6 centimeters, it's way too big. Mm-hmm. So they can't. It's not like other, like cancerous or mass type growths that people might have, where it might get huge. An aneurysm is going to get only so big, and then something bad's going to happen. So the other thing that can happen to the aorta is something called aortic dissection, and this is something that often gets confused with aortic aneurysms. But an aortic dissection has to do with the sudden separation of the layers of the aorta. The typical artery has 3 different, types of tissue layers, and due to a number of different things, sometimes those layers of the aorta can actually separate. So it's kind of like a pipe.
So now you're putting space in between them?
Yeah, right. Yeah. Well, in blood will start to go into, the layers will separate, and blood will start to move into that layer, separating it more, making it weaker, possibly, cutting off the flow to branches off the aorta. And this can often be a catastrophic event. People refer to the chest pain, and often they have a sudden episode of chest pain, and it's often referred to as a tearing kind of pain or a ripping kind of pain. And you can kind of almost envision, having this ripping kind of pain.
Funny you say that, because I was starting to think that when you were talking about it. Wait, what does that feel like? Must feel great.
Yeah, it doesn't feel good.
No.
Unfortunately, when you start to feel that symptom, it's too late to do anything that's going to avoid the event. But at least you know what's happening. Any sort of chest pain in any way that it might be described as something that usually needs evaluation. But and also this is something else that as the first symptom of an aortic dissection is often the only one and can be fatal. But so I wanted to get to quickly, another incident or another instance of venous disease leading to sudden death, and this all came to mind here recently. I was reading an article in one of the journals about an 88-year-old guy who was living alone. He was found in a pool of blood by neighbors, and he was dead, and I think there was a big, kind of investigation, police investigation.
Because of the blood.
And, and they figured it was a homicide of one form or another, but they investigated the whole scene. He was found laying on his back in bed. His legs were over the edge of the bed, and, a huge pool of blood. And they actually did blood stain pattern investigation and all this sort of stuff. It was a very forensic sort of event, but in the final analysis, they found out that he had actually ruptured a small spider vein.
Yeah, wow.
And again, we've talked about that kind of thing before. But tiny little vein way down on his ankle. And sometimes those tiny little spider veins can actually, erode the surface of the skin to the point where bleeding occurs. And now that death is not the usual result. I mean, 99% of the time, the bleeding is easily controlled and people get evaluated for that problem, but that can be one of the complications of long-term vein disease.
Yeah, and you mentioned that before. That was just, normally you wouldn't expect that sort of activity out of a spider vein, but it just goes to show you that things are all connected. And even spider veins probably ought to be looked at every now and again to say, these things have gotten worse over the years, so are they starting to be a problem?
Yeah. And the spider veins that bleed are of a particular appearance and location and quality. So, it's pretty easy for us to identify those, small superficial spider veins that are at risk for bleeding, and usually we are able to do something about that before the event occurs.
Okay, and I think what's mainly for you to understand the takeaway today is when Doc first, decided to do this program and call it sudden death and vein disease, his first big caveat was saying it's probably going to happen only to a very, very few of us. But if we can just intervened on one person's behalf today, we would have done it. But
sure.
I think isn't it just really getting in tune with what your body is, especially as we're aging way more than we used to. We just need to keep a better eye on things.
Mm-hmm. Yeah.
Very good. Okay, if you need to get more information about what we've talked about today, or to learn more about what happens at Vein Clinics of Hawaii, please go to veinclinicsofhawaii.com, veinclinicsofhawaii.com. And remember, that these programs are brought to you, and you should get in the pebble in the pond. Let other people know that you heard the show, or come back and visit us again. And also, some of these things down the road are going to be linked on the website, veinclinicsofhawaii.com. So please take care of yourself and enjoy the rest of your weekend, and we'll see you next time. Right here, and like I said, let everybody know what we've been doing, and we'll be back next week.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, VeinClinicsOfHawaii.com. That's VeinClinicsOfHawaii.com.